Welcome to the Kanski lecture series, and today we are going to start chapter 4 orbit, and this is the part 1. So, for me, the orbit is a very interesting chapter because there are many diseases that comes to you with the complaint of orbit. Uh, so, let's get started. Introduction Anatomy. So in this part we are going to discuss about the anatomy of the orbit in which the eyeballs lie. You know that the orbit roughly has a four walls, that is superior roof, that is superior part. Then there is a medial wall, there is a lateral wall, and there is a floor. And the orbit is basically pear shaped cavity like this, and there is an apex, and through which the optic canal passes. The orbit is a pear shaped cavity, the stalk of which is an optic canal. The roof consists of two bones, the lesser wing of sphenoid and the orbital plate of the frontal bone. It is located subjected to the interior cranial fossa and the frontal sinus. The defect in the orbital roof may cause pulsatile proptosis due to the transmission of the cerebrospinal fluid pulsation to the orbit. So, basically, the roof consists of two bones, that is the lesser wing of sphenoid, and another is a frontal bone. And above the roof is basically the anterior cranial fossa and the frontal sinus. And whenever there is a defect in the roof, it will causes the cerebrospinal fluid um, through the roof, and it cause the pulsatile proptosis, and it is a very common in cases of like encephalocele. The lateral wall also consists of the two bone, the greater wing of the sphenoid and the zygomatic bone. The interior half of the globe is vulnerable to the lateral trauma since it protrudes beyond the lateral orbital margin. So the lateral orbital margin consists of the two bones, that is a greater wing of sphenoid and the zygomatic bone. It is a quite mm, resistant wall. It is not so much prone to in fracture, but the interior globe that protrudes along the lateral wall is prone to trauma. Floor consists of the three bones, the zygomatic, maxillary, and the palatine. The posterior medial portion of the maxillary bone is relatively weak and may be involved in a blowout fracture. So the the weakest part of is the floor, and the more common fracture that you will encounter is the floor fracture, and it consists of the three bone, zygomatic, maxillary, and the palatine bone. The orbital floor may also form the roof of the maxillary sinus, so that maxillary carcinoma invading the orbit may displace the globe upward. So there behind there is a maxillary sinus. Medial wall consists of the four bone, maxillary, lacrimal, ethmoid, and sphenoid. The lamina papyracea, which forms a part of the medial wall, is paper thin and perforated by the numerous foramina for nerves and blood vessels. Orbital cellulitis is therefore frequently secondary to ethmoidal situs. So, orbital medial wall consists of the four parts, that is a maxilla, lacrimal, ethmoid, and the sphenoid bone, and medial to it is a ethmoid sinus. So whenever there is a sinusitis, it can also cause orbital cellulitis. So these are the anatomy of the orbit. So you can see the frontal bone, you can see the roof is made up of the frontal bone and the lesser wing of the sphenoid, whereas the lateral bone is made up of the zygomatic part and the greater wing of the sphenoid, and between them is the superior orbital fissure is basically between the greater and the lesser wing of the sphenoid, and there is an inferior orbital fissure, and then there is a uh, inferior wall that is mainly consist of the maxilla, and the floor is made up of the maxilla and zygomatic and palatine bone, and the medial wall consists of the ethmoid lacrimal, ethmoid, and sphenoid and maxillary bone. So, the superior orbital fissure is a slit linking the cranium and the orbit between the greater wing of the sphenoid and the lesser wing of the sphenoid. The number of important structure passes through the through it. So, look at this picture and you will identify there is a superior orbital fissure that is between the greater and the lesser wing of sphenoid, and between is it in the or optic canal. The superior portion consists of the lacrimal, frontal, and trochlear nerves and the superior ophthalmic vein. The inferior portion consists of the superior inferior division of the oculomotor nerves, abducen and the nasociliary nerves, and the sympathetic fibers from the cavernous plexus. So, superior orbital fissure is then divided into superior portion and the inferior portion, and the superior portion has a LFT, passes LFT, lacrimal, frontal, and trochlear nerves and the superior ophthalmic vein, whereas the inferior portion consists of the oculomotor nerve, superior and inferior branch, third, sixth, and nasociliary nerves and the sympathetic fibers from the cavernous plexus. Inflammation of the superior orbital fissure and apex Tolosa-Hunt syndrome may therefore result in a multitude of signs, include ophthalmoplegia and venous obstruction. Why? Because different nerves passes through the apex and the superior orbital fissure. So whenever there is an inflammation around it, it will cause the ophthalmoplegia. Means there will be no movement of the eyeball and there will be the venous outflow obstruction. Then there is an inferior orbital fissure that lies between the greater wing of the sphenoid and the maxilla, connecting the orbit to the pterygopalatine and the infratemporal fossa. So this is a inferior orbital fissure between the greater wing of the sphenoid and the maxilla, and it will connect to the posteriorly to the pterygopalatine and infratemporal fossa. Through it runs the maxillary zygomatic nerve and the branches of the pterygopalatine ganglion and inferior ophthalmic vein. So its mnemonic is ZIP. Zygomatic nerve, inferior ophthalmic vein, pterygopalatine ganglion branches, and maxillary nerve. The sensory supply of the eye and the orbit is shown. So you can see figure 2.3. So you can see that here is what is the optic canal. Here is an optic canal, and between it passes the optic nerve and ophthalmic artery. And then there is a thing called common tendinous ring. The common tendinous ring is basically that in which is the insertion of the four recti origin of the four recti muscle, and it divides the superior orbital fissure into superior part and inferior part. The superior part is outside the tendinous ring, and through it passes the LFTs and superior ophthalmic brain branch, that is lacrimal branch of the ophthalmic nerve, frontal branch of the ophthalmic nerve, and trochlear nerve. And below it lies the third nerve, superior branch, nasociliary branch of the ophthalmic nerve, obtuse nerve. And there will be the inferior orbital fissure, there will be the inferior ophthalmic vein. And so this is showing the sensory nerve supply of the orbit. You can see the this is an oculomotor nerve that is divided into superior branch and the inferior branch. So the superior branch will supply the superior rectus and the levator muscle, and below it, and the inferior branch will supply the inferior oblique, and it will also supply the inferior rectus and medial rectus as well. Nasociliary nerve and abduced nerve, and there is a ciliary ganglion, there is a lateral rectus, lacrimal nerve, There is a lacrimal gland which supplies which whose sensory supplies lacrimal nerve. There is long and short ciliary nerves, and then there is a medial rectus muscle. This is an infratrochlear nerve, anterior ethmoidal nerve, and posterior ethmoidal nerve. So this is basically the anatomy of the orbit. So then there are the clinical features which suggest basically the orbit inflammation or orbital disease. So symptoms are of orbital disease include eyelid and conjunctival swelling. So there can be the swelling of the eyelids and conjunctiva. There will be the redness, watering pain, sometimes on exacerbated by eye movement. Increased ocular prominence, that is proptosis, is one of the signs of the orbital disease. Displacement or a sunken impression of the eye, double vision, blurring, and sometimes a pulsating sensation or an audible brew. So whenever what happens if there is a soft tissue involvement? Eyelid and the periocular edema, skin discoloration, ptosis, chemosis, edema of the conjunctiva, which may involve the plica and the truncal, and epibulbar injection may be seen. Causes include thyroid eye disease, orbital inflammatory disease, and obstruction to the venous drainage. So whenever there is a soft tissue involvement, there will be the swelling of the eye, and there will be the edema, and there will can be the chemosis as well. So proptosis is one of the very important topic. It is basically denoted the abnormal protrusion of an eyeball. So basically usually the proptosis refers to any abnormal protrusion, but and in eye it is special cause exophthalmos. Proptosis describes an abnormal protrusion of an organ, but its journey applied to the eyeball. Exophthalmos refer specifically to the eyeball only. Proptosis may be caused by the retrobulbar region or less frequently a shallow orbit. The intraorbital portion of the optic nerve is longer, 25 mm, than the distance between the back of the globe and the optic canal. This allows for the significant forward displacement of the globe proptosis without excessive stretching of the nerve. So basically, between the optic canal and the eyeball, there is a distance. There is a distance through which the optic nerve lies, and the distance between the eyeball and the optic canal is usually about 18 millimeter, but the optic nerve is 25 millimeter. So whenever there is a proptosis, it can occur without stretching of the nerve. So you can see figure 4.4. This is showing us the soft tissue swelling, that is there is a chemosis and injection of the orbital disease, and it is showing proptosis. There is an abnormal protrusion of the eyeball. So there can be asymmetrical proptosis between two eyes. The asymmetrical proptosis is radically detected by looking down at the patient from above and behind. So you can see figure 4.6a. You are seeing a patient from above, and you can see there is a significant protrusion of the left eyeball. The direction of the proptosis may indicate the likely pathology. For example, space occupying lesion within a muscle cone, such as cavernous hemangioma or an optic nerve tumor, causes axial proptosis, whereas extracorneal lesion usually give rise to a combined proptosis and dystopia. So there are commonest tendon ring and any lesion, and there is an eyeball through which the optic nerve passes. So whenever there is a lesion that is between the muscles, which is called the intracorneal lesion, there will be the axial proptosis, mean the eyeball will be just protruded in the straight direction. Whereas in cases of extracorneal mass, there will be the proptosis as well as dystopia, mean it can the eyeball can go down or up as well. So one of the very common axial proptosis is cavernous hemangioma, which is an intracorneal mass. Dystopia implies to the displacement of the globe in the coronal plane, usually due to an extracorneal orbital mass such as lacrimal gland tumor. So whenever there is a lesion or a mass that is extracorneal, there will be the dystopia, mean the displacement of the globe in a in some direction. It is not usually straight, it will have some direction. Horizontal displacement is measured by the midline of the nose or to the center of the pupil, while the vertical dystopia is read on a vertical scale perpendicular to the horizontal rule placed over the bridge of the nose. This measured eye should fixate the straight ahead, if necessary, facilitating this by occluding the fellow eye. So, what is it trying to explain is that there can be the vertical dystopia and there is a horizontal dystopia. So, horizontal dystopia mean the eye can move laterally, and vertical mean it can move up and down. So, how to measure such kind of proptosis? For example, this is a patient, and this is a patient nose, and it has an eye that is deviated slightly outward and downward, whereas this eye is at its normal position. So how will you measure that, how much displacement is it? Basically, you take the ruler, you scale, and you start measuring this from the pupillary axis, and you will say also measure from the center of the nose to the pupillary reflex from here, and the difference will then guide us how much is the lateral dystopia or horizontal dystopia. After that, you measure the vertical dystopia. How will you measure? You put another scale downwards from the tip of the nose, and then you will measure from here to the center of the pupil. Pupillary reflects the distance between upside and this side, and you also measure it from this side of the nose, and then you will see how much it is displaced downward. So this will give us the vertical dystopia measurement. The severity of the proptosis can be measured with the plastic rule resting on the lateral orbital margin, or with a Lude exophthalmometer using a similar principle. So what you is basically, for example, this is an eyeball and this is a lateral canthus. So you put the scale here and you measure the apex of the eyeball, and this will give you the measurement of the proptosis. But there are certain exophthalmometer that is present, for example Hertel exophthalmometer. It will give us the measurement of the proptosis. Usually the less than 21 millimeter from the lateral orbital margin to the apex of the cornea is normal measurement, and above it is causing the proptosis. Commonly, binocular exophthalmometer, for example Hertel, is employed using a visualization of the corneal apices to determine the degree of the ocular protrusion from the scale. Measurement can be taken both relaxed and with the Valsalva maneuver. Reading greater than 20 mm are indicative of proptosis, and a difference of 2 to 3 mm or more between the two eyes is suspicious regardless of the absolute values. So if it is greater than 20 mm, it is indicate proptosis, and if one eye is normal and other eye is slightly proptosed, then if the difference is greater than 2 to 3 mm, you can say that it is a proptosed eye. The dimensions of the palpebral apertures and any lack of thalamus should also be noted. Pseudoproptosis. So pseudoproptosis is a term like a pseudotosis in which there is no actual proptosis, but due to the other eye condition or pathology, the normal eye looked proptose. For example, other eye have some kind of anophthalmos or ptosis, then the other eye looks having the pseudoproptosis. So the pseudoproptosis is the false impression of the proptosis, which may be due to facial asymmetry, enlargement of the globe, for example high myopia or ophthalmos, lid retraction, or contralateral anophthalmos. So for example, there is a lid retraction, it can cause a false impression of pseudoproptosis. If the contralateral eye is anophthalmos, then it can give an impression of the proptosis. Another, when the eyeball is large, for example in case of the high myopia ophthalmos, it can also give an impression of the proptosis. Enophthalmos. Enophthalmos implies the recession of the globe within orbit. Causes include congenital and traumatic orbital wall abnormalities, atrophy of the orbital content, So whenever the globe is normal globe is pushed back, it is called the ain of thalmos. X of thalmos is protrusion, where the in of thalmos is going back of the eyeball. And it is because the there can be the orbital wall trauma to the orbital wall, like an orbital wall fracture. If there is some atrophy of the orbital content, for example in cases of radiotherapy, scleroderma, chronic eye poking in blind and fans, the oculodigital sign, or sclerosis, for example metastasis, cirrhosis, carcinoma, sclerosing, orbital inflammatory disease. Pseudoanophthalmos may be caused by a small or shrunken eye. So whenever there is uh, an ophthalmos, the eyeball, um, it is an pseudo anophthalmos means there is an impression of the recession of the globe, but it is usually caused by the eyeball pathology. For example, there is a small or shrunken eye, for example microphthalmos or phthisis bulbi, by ptosis or by contralateral proptosis or pseudoproptosis. It can give the impression of anophthalmos. So ophthalmoplegia is one of the another sign of the orbital diseases. For example, defective ocular motility is very common in orbital disease. Causes include an orbital mass, restrictive myopathy, for example thyroid eye disease, orbital myositis, teething of the muscle or tissue after orbital wall fracture, oculomotor nerve abnormal involvement associated with lesion in the cavernous sinus, orbital fissure or posterior orbit, for example carotid cavernous fistula, Tolosa Hunt syndrome, malignant lacrimal gland tumors. So in case of the orbital disease, there can be the ocular motility defect. Why? Because you know that through the apex there are lots of nerves coming or going, and because of this, whenever this is compressed, these nerves are compressed, so it will give the ophthalmoplegia, means that the nerves are not working properly. And restrictive myopathy is basically a condition in which the muscle itself are problematic and they are not moving. For example in case of thyroid eye disease, and there can be the orbital myositis, mean there will be the inflammation of the muscle, and there can be the orbital wall fracture, and there is a uh, problem in the cavernous sinus. There will be the oculomotor nerve involvement. There can be the, and in the posterior orbit there can be the CCF, Tolosa Hunt syndrome, and the lacrimal gland tumors can also cause it. Forced suction test, and so these are some. Forced suction test is a very important test. Basically it is used to give us the idea that the restrictive movement is either due to a palsy or due to a restriction of the muscle. So what you do is basically, for example this is an eye and this is a globe, a sclera, and there are four rectors that are inserted into it. So you take make anesthesia and give a topical anesthesia, and you hold the limbus and move the eyeball in the direction of the muscle. For example, if you are checking the superior rectus, you will pull the um, superior limbus, and then you will move the try to move the eyeball up. If it moves up, then it means that there is no restriction, but if there is no movement, that means that there is a superior rectus muscle restriction. Forced suction test and the topical anesthesia, the insertion of the muscle of an involved eye is grasped with the forceps and the globe rotated in the direction of the reduced motility. Check movements of the globe indicate a restrictive problem. No resistance will be encountered with a neurological lesion. Differential IOP test, which is also known as a Braille sign. What is a Braille sign? Is basically you take an IOP of an eye in a primary gaze position, and you are after that you ask the patient to look in the direction of the restrictive eye restrictive portion. And what happens then if you take the IOP again, if the difference between is greater than 6 millimeter mercury, it is known as positive and it is a Braille sign. It means that there is a restriction. Differential IOP test involves a less discomfort than forced action and objective rather than a subjective endpoint. The IOP is measured in the primary position of the gaze and then with the patient attempted to look in the direction of a limited mobility. An increase of the 6 millimeter mercury or more denotes resistance transmitted to the globe by muscle restriction, the Braille sign. Saccadic eye movements in neurological regions lesions are reduced in velocity, while the restrictive defect manifests normal saccadic velocity with the sudden halting of the ocular movements. So scading scades is also the way to check about the restriction of the movement. So what do you do is basically ask the patient to look from one target to another, and what happens is in case of a restrictive defect in the neurological defect, there will be the no saccades or reduced. But in case of a restrictive defect, there will be the saccadic normal saccadic velocity with the halting of the ocular movement. So for example, if we ask the patient to look from here to here and there is a restriction here in this muscle, so whenever the patient is looking here, there will be the movement, but there will be the sudden halting of the movement. There is a dynamic properties. There is an increasing venous pressure by the dependent head posture, head position. The Valsalva maneuver or a jugular compression may induce or exacerbate proptosis in a patient with the orbital venous anomalies or infants with the orbital capillary hemangioma. So whenever there is a vascular conditions, like in case of the hemangioma, and you ask the patient to have some Valsalva maneuver, like just uh, uh, put hands on your nose, or you just head down for a while, there will be the increase in the proptosis. It means that there is a vascular increase in the venous pressure. Then there is a pulsation. Pulsation is either caused either by the arteriovenous communication or a defect in the orbital roof. In the formal, the pulsation may be associated with a bruit depending on the size of the communication. In the later, the pulsation is transmitted from the brain by the cerebrospinal fluid and there is no associated bruit. Mild pulsation is best detected on the slit lamp, particularly by the applanation tonometry. So pulsation means like the eye is having a pulse, like you can see that there is a sudden increase and decrease of the eyeball, and the pulsation suggests that there are two things. If there is a orbital wall defect, for example, there is a fracture of the orbital roof, or there is a encephalocele and there is a opening or connection between the brain and the orbit, it will cause the pulsatile proptosis. And in other cases in which there is an arteriovenous communication, it will also cause the pulsatile proptosis, and it is in the case of the carotid cavernous fistula, but in that case there will be also a bruit present. So what is a bruit? Bruit is basically you ask the patient to close their eyes and you take the bell on the patient eye, you put the bell on the patient eye and then you listen to the bruit. And what happened is that if there is a carotid cavernous fistula, there will be the bruit present. A bruit is found with the larger carotid cavernous fistula. It is best heard with the bell of the stethoscope and is lessened or abolished by gently compressing the ipsilateral carotid artery in the neck. So while doing the procedure, when you press the carotid artery, there will be the decrease in the bruit. So whatever in the fundus of an eyeball, if there is a orbital pathology, so there can be the optic disc swelling, that may be the initial features of the compressive optic neuropathy. So whenever the optic nerve is getting compressed, it is showing that there is an compression of the optic nerve, there will be the optic disc swelling. So optic atrophy usually settled after the long term optic disc swelling. Optic atrophy, which may be preceded by swelling is a feature of a severe compressive optic neuropathy. Important causes include the thyroid eye disease and optic nerve tumor. Opticociliary collaterals. Opticociliary collaterals consist of the enlarged pre-existing peripapillary capillaries that divert the blood from the central retinal venous circulation to the peripapillary choroidal circulation. When there is a obstruction of the normal drainage channel on ophthalmoscopy, the ophthalmoscopy, the vessel appears as a large tortuous channel more frequently sided temporally, which disappear at the disc margin. The collaterals may be associated with an orbital or optic nerve tumor that compresses the intraorbital nerve and impairs blood flow through the central or retinal vein. The common tumor associated with the shunt is an optic nerve sheath meningioma, but they may also occur with an optic nerve glioma, central retinal vein occlusion, idiopathic intracranial hypertension, and glaucoma. So there is a thing known as optociliary collaterals. What happens is, for example, this is a fundus and here is a disc. So you can see that there is a cup and there is a disc. There is a cup and disc. So optociliary collateral is basically the peripapillary capillaries. They direct the blood flow from the retinal artery to the choroidal circulation, and when this happens there will be the dilation and tortuosity of that capillaries. So it will occur as a glue, but one thing very important, it disappear at the disc. So these are known as collaterals. And most important is a part of it can happen in glaucoma, it can happen in CRVO, and it can happen in glioma, it can happen in optic nerve sheath meningioma, and it can happen in an orbital disease. Choroidal folds are discussed in detail in chapter 14. They may occur in a wide variety of the orbital lesion, although tending to be more severe with greater amounts of proptosis and anteriorly located tumors. In some cases, their presence can precede the onset of proptosis. So these are the signs. B is showing the inferior dystopia. C is showing the measurement of proptosis with an exophthalmometer, which is known as Hertel. And so this is showing the restrictive myopathy and bilateral lid retraction. So there is a lid retraction and there is a restriction of the gaze. So this is a primary position of the gaze, and there is a in the right gaze, and this is showing us the left gaze. This is showing the down gaze, and it is showing the dextro depression, it is showing the levo depression, it is showing the dextro elevation, it is showing the levo elevation. And so these are the fundus changes, and A is showing the dusk swelling, B is showing the optic atrophy with choroidal folds, C is showing the optociliary vessels in the presence of the optic nerve. So these are the optociliary collaterals, and D is showing the choroidal folds, which is not very clear. So what type of investigation that you can perform in case of an orbit disease? You can perform CT scan, MRI, plain X-rays, ultrasonography, fine needle biopsy. CT scan is useful for depicting bony structure and the location and size of the space occupying lesion. It is of particular value in a patient with orbital trauma because it can detect a small fracture, foreign bodies, blood, herniation of extraocular muscle, and emphysema. It is, however, unable to distinguish between the different pathological soft tissue mats that are radiologically isodense. Confirmation of an orbital abscess in a cellulitis is a relative common indication. So you perform CT scan whenever you are want to see about any space occupying lesion, or you can see any fracture, or you want to see any foreign body trauma and other kind of condition. But in case of the soft tissue details, you have to perform an MRI. MRI can demonstrate orbital apex lesion and intracranial extension of the orbital tumor, and is useful for orbital Imaging orbital inflammatory disease. Serial short T1 inversion recovery scans are valuable in assessing inflammatory activity in thyroid eye disease. Plain X-rays are little used except for the initial diagnosis of the traumatic bone injury. Ultrasonography can provide the full useful information, particularly with high grade operators and an experienced operator, but does not image the orbital apex well. Fine needle biopsy is sometimes performed, particularly in suspected neoplastic disease. Potential problems include hemorrhage and ocular penetration. Tip: the most common tumor associated with optociliary shunt vessels on the disc is an optic nerve sheath meningioma. So that's it for the orbit part 1. See you in the next lecture.